Hi class, I'm Jamie Batts. We are going to continue on with our review of renal physiology, and we just finished talking about how our urine is formed in the last lecture. Let me jump here into my little PowerPoint and we can look at what happens in renal failure. I've alluded to a few things already throughout the lecture videos. Renal failure basically is when our kidneys cannot perform the functions that they need to in order for our body to maintain homeostasis. So all systems of the body need the kidneys to function appropriately. When your kidneys are not functioning appropriately, you're going to have reduced urine production, which is going to disturb your overall body fluid balance, your pH, how your muscles contract, right? Your overall metabolism, your digestive function, all of these, because all of your systems along the way have needed calcium and sodium, right? Think about, just how your nervous system functions, right? You need your calcium at that synaptic cleft to let the ACH out, right? You need sodium and potassium to propagate an action potential. Your heart needs sodium to initiate a contraction. Your heart needs calcium to maintain a contraction and not undergo tetanus. Your blood needs calcium just for clotting, right? And potassium for clotting. These both of them really. Hypertension can result when your body is not getting rid of the excess fluid. Therefore, you might have some edema and bloating, right? Anemia, because EPO is not being released and therefore red blood cells are not being created. Therefore, you're not going to have enough oxygen floating around in your body. Central nervous system problems, including seizures and maybe even coma, resulting from just simple, quote unquote, kidney failure. So, chronic kidney failure is when your kidneys are deteriorating over time. This is something that is easily, detected fairly early in age and just progresses. So the progression can be slowed, but the condition is not reversible. Our kidneys do not renew themselves like, say, our liver. So overall management of kidney failure, chronic renal failure, would be restriction of water and salt, as well as protein intake. So that's going to reduce the strain on your urinary system by limiting the amount of volume of urine that's produced, as well as the amount of nitrogenous waste that are being produced, so that your body's not having to sort and process all of that. Acidosis can result, which is a very common problem with renal failure, and you can just have a bicarbonate supplement to help counterbalance that. There's also acute renal failure. This is when your kidney failure or your kidney function deteriorates very quickly over just a few days. They may be impaired for weeks at a time with acute renal failure. Sudden slowing or stopping of filtration can be caused by drugs, ischemia, lack of blood flow, some type of urinary obstruction, or maybe even a trauma. It could also be caused by an allergic reaction to antibiotics or anesthetics, or anyone who's already been sensitized to that particular allergen. The recovery could be partial or complete. It depends on the specific incident, and it has a fairly successful survival rate because you have two kidneys, so you kind of have like a backup plan. Dialysis is one of the solutions for renal failure. It's where you're passively diffusing the solutes across a selectively permeable membrane. So you're basically going to an artificial kidney and having this artificial machine filter your blood for you. Hemodialysis uses this artificial membrane to act as a kind of alternative to your body's own glomerulus, regulating the composition of the blood. Typically someone on kidney dialysis, someone that has kidney failure, that is on kidney dialysis, has to go every 2 to 3 days to a clinic to undergo dialysis. So the dialysis fluid has specific concentrations. It's very similar to the peritubular fluid of our own kidneys, and there can be shunts or little tubes that kind of connect the blood vessels to the dialysis machines. It's not a fun process, but it's a necessary process for people with kidney failure. That's just showing you the dialysis membrane set up the same way as our actual kidneys are, creating a membrane instead of the actual renal tubule that you're used to thinking about. So this is looking at the comparative composition of the blood plasma to dialysis fluid. You'll see it's very similar to the peritubular fluid of our own bodies. It's working to create the same concentration gradients that we have in our own bodies, so the same types of concentrating and removal of waste products will occur through the dialysis machine. So the treatment of renal failure will involve dialysis, but it's just a temporary fix. It's not a cure in any way. And if you've ever known anyone on kidney dialysis, it's quite a burden to bear, because again, you have to go every couple of days, and imagine if there's a big storm and you're stuck in your house or something. It can be very tragic. So kidney transplant is really the only cure for individuals who have severe renal failure. Patient survival rate's very high, 90%. Up to 2 years after the transplant. Typically, there would be a close relative that would be the donor that would have the best success rate because of your tissue compatibility. Immunosuppressive drugs have to be taken to reduce the risk of rejection for that new tissue. So you can pause the video here, go back and review this section. We're going to keep moving on through urine storage and elimination. It's pretty straightforward, so we'll try to zip through it. Our overall urinary tract, right, is storing, transporting, and eliminating the urine. We mentioned this already. The filtration modification is all done at the kidney level, and it stops once that filtrate reaches the renal pelvis. So the ureters, the urinary bladder, the urethra are the parts of our urinary tract, and a image called a pileogram, I can never say it, pileogram, I'm a horrible pronunciator, is basically an X-ray image after a radioactive dye has been taken, and it's usually administered intravenously, and so you can see the illumination of the urinary tract, typically done if someone's have like kidney stones or something like that. So the ureters themselves are these small little muscular tubes, smooth muscle of course, from the kidneys to the bladder, the retroperitoneal. The bladder is a hollow muscular organ, can hold up to 1 liter of urine, and then the urethra itself is the tube that eliminates the urine from the body. There is the pileogram. There we go. See the right kidney, the left kidney there. This is taken from the back. And the urethra, going from the neck of the urinary bladder all the way to the back of the body. Different lengths, obviously, and different functions in males versus females. The male urethra is much longer, and it has a dual role of carrying not only urine, but also semen. So, and we'll look at that more when we cover the reproductive system. So here you can actually see a nice sagittal section of the urethra. Obviously, I don't know, maybe it's not obvious. The male urethra is much longer than the female urethra. You can pause the video here, go back and review this section. Let's talk about how our urine is stored and how does it move from one place to the other. So our urinary bladder is filled from the ureters. The ureters basically empty right into that urethra. I kind of think of like I don't know, I come from my dad was a mechanic, so I always think of like the dripping oil pan, right? That's kind of like that pan is just holding the urine, right? Or oil in that case. The dimensions of the urinary bladder are going to vary depending on how much fluid is already in the bladder. Its posterior, inferior, and anterior surfaces are actually outside of the peritoneal cavity. It's anchored in place by ligaments, the lateral umbilical ligament and the middle umbilical ligament, holding it to the pelvic and pubic bones. Inside the bladder are ruggy, just like inside the stomach. That's going to allow for that expansion. There's also ureteral openings on either side. They're like little slits that help prevent the backflow of urine into the ureters and kidney. The ureters go into the back side at an oblique kind of side angle into the urinary bladder. There's a section of our bladder called the trigone. This is just a triangular area that is right at the entrance of the urethra, kind of like a funnel is what it is. It's just this funnel area channeling all of the urine into this space. As the urethra and bladder kind of contract, it's going to allow for the flow of urine to go in that one direction that we want it to. The neck of the urinary bladder surrounds the urethral opening. It contains an internal urethral sphincter, which is an involuntary smooth muscle And then the external urethral sphincter is voluntary. Thank goodness, right? Otherwise, we'd just pee our pants all the time. It says under voluntary control, and it has to be relaxed in order for urination to occur. There is everything. This is on the male because there's a prostate here. So you see the ureters coming in towards the back. They kind of enter on the posterior side, and which most people would think they would go at the top, right? But nope, they come all the way down towards kind of like the bottom. And everyone is a little bit more sensitive to how full their bladder is. Some people feel like they have to pee, right? When, there's just this little bit in there, and some people don't feel like they have to pee until it's almost all full. So that is all very relative. But either way, those ureters are there. The trigone is this nice triangular funnel. The neck is just this small narrowed portion. And you have the internal urethral sphincter there. The external urethral sphincter is more exterior, hence external, right? And on males, it's just past the prostate. The prostate's going to regulate this part of the urethra. We'll see the male urethra is much different. The prostate's kind of going to close off this part of the urethra and allow for the semen to kind of come through. So the prostate kind of regulates which substance is going to pass through. The ureters themselves have 3 different linings, kind of like any other area of our body. It has all these tissue linings to it. The inner mucosa is transition epithelium. You might remember that from like chapter 3. There's a muscular band and then an outer connective tissue layer holding it all together. Fibrous collagen and elastic fibers holding it all together. That inner band of muscle is smooth muscle, right? It's going to move in like a peristaltic fashion and contract in that same manner. There you see a nice cross section. You can see those 3 layers of the mucosa, transition epithelium, the smooth muscle layer, and then the outer connective tissue layer. The urinary bladder itself has a mucosa, a submucosa, and a muscularis layer. The muscularis layer has 3 layers of muscle, a longitudinal, a circular, and an outer longitudinal. There's also a detrusor muscle. The detrusor muscle is going to compress the urinary bladder to really squeeze down and allow for that urine to get into the urethra. So there you see the detrusor muscle is this kind of extra layer there. Extra thick muscular layer, detrusor muscle. The wall of the urethra is lined with stratified epithelium, right? Anytime we have like a passageway and that's no absorptions occurring, it's going to be stratified epithelium. There's a transition at the neck and then stratified columnar in the middle. But for the most part, it's stratified squamous and a thick lamina propria and mucin secreting cells within that mucous membrane to help lubricate any fluids that are going through, make sure that it's not going to damage any of the tissues, because our urine is slightly acidic typically, so that those mucins are there to help counteract that. There you see the lumen. And you can pause the video here, go back and review this section. We have one little section left, I believe, and that's on the process of urination itself, which is called the micturition reflex. This is the coordinated process of urination itself, and there's a reflex pathway, there's a local and a central pathway. Just like our defecation reflex, we had a short reflex and a long reflex that controlled that. We have the same kind of thing here. So with the local pathway, there are stretch receptors that are going to basically detect that our urinary bladder has been distended, and it's going to carry impulses to our spinal cord. And parasympathetic motor response is going to allow our detrusor muscle to compress the bladder, because squeeze down. This is going to increase the hydrostatic pressure in the bladder, right? Makes you feel like you really have to go now. With the central pathway, you have an interneuron that's relaying this sensation up to the thalamus and then to our cerebral cortex. So it becomes into our conscious awareness at this point with our central pathway. So then we can voluntarily relax that external urethral sphincter when we're ready, right? You might feel like you have to pee right now, but don't, unless you happen to be watching me while you're sitting on the toilet, in which case I don't really want to know about it. But if you're sitting at a desk like I am, you probably don't just want to pee while you're watching this video. So you're going to feel that, you're going to be consciously aware of it, and then when you're done watching this video, in about, 4 4 minutes or so, you can then go and relax your external urethral sphincter as needed. Here is the whole loop happening. You see the stretch receptors traveling to the afferent fibers, letting our internal urethral sphincter relax, and the contraction of the bladder as a whole, squeezing down, increasing the hydrostatic pressure. As that happens, the interneuron from this reflex pathway is going to take that information up to the thalamus. All sensations go to the thalamus. Remember, thalamus is our kind of sensory relay center. And then all of that goes up to the brain for our conscious, up to our brain. It's all in our brain. Up to our cerebral cortex, where it becomes our conscious awareness, and then over to our external urethral sphincter when we're ready. You can pause the video here, go back and review this section. Let's talk about some urinary disorders. There are a variety of urinary disorders. Any change in volume and appearance of the urine would be an indicator of a urinary disorder. Polyuria is excessive urine production. This could be from a hormonal or a metabolic problem like diabetes or glomerular nephritis, something going on in your kidneys, right? Oliguria, this is reduced urine production, right? As little as 50 milliliters per day. Oof, goodness. Anuria is when you almost have none. Oliguria and anuria can indicate a very serious kidney problem and renal failure. So definitely, if you haven't gone in a while, get that checked out. So any change in frequency, increased urgency or frequency of urination can be from the irritation of the lining of the ureters or urinary bladder itself. So you need to obviously get that checked out. Incontinence is actually the inability to control your urinary function or control your the release of urine. So this could involve involuntary leakage from stress, incontinence, or the inability to delay urination where you have urge incontinence and once you feel it, you have to go right away. Or it could be a continual trickle of urine from a full bladder, which would be overflow incontinence. So stress incontinence can result, I should say, after periods of pregnancy and childbirth where that whole pelvic floor and all of those muscles have been overstressed and they're just not like they used to be, so to speak. And so, sneezing, jumping, and things like that, a lot of women suffer from stress incontinence related to pregnancy issues. So there's also a change in frequency like in urinary retention. So normal renal function is fine, but if urination doesn't occur, like if you just keep holding it and you can't let it go, this could indicate an issue specifically in males. Males, if they have an enlarged prostate or something going on with their prostate. Remember, the prostate is the regulatory mechanism between the vas deferens and the urethra, kind of shunting, which product, so to speak, is going to be released. So if there's something going on with your prostate, males might not be able to release that internal urethral sphincter to allow the urine to come out. And so that could obviously be dangerous as well. There could be pain in the superior pubic region that could be associated with any urinary bladder disorders, or pain in the upper lumbar region could indicate something going on with your kidneys. So you have to pay attention to where those pains are coming from. Dysuria is painful or difficult urination. This can occur with like cystitis or urethritis or any urinary obstructions like an enlarged prostate. So this is just looking at where that pain may be and what could be causing it. Other urinary system disorders or signs of urinary disorders, as we mentioned, because your kidneys have this intimate relationship with your blood, if they're not filtering like they should, you're going to see other signs. For instance, edema or swelling. This can occur when you have proteinuria or protein in your urine. Facial swelling, especially around the eyes, is a good indicator of something going on with your kidneys, because if your body's secreting proteins in the urine, that means those filtration slits are too big, and that means your blood colloid osmotic pressure is way off. That means you're not reabsorbing at the capillaries like you need to be, with your normal capillaries, not just the glomerular capillaries. So it's creating this excess interstitial fluid. Fever can result as well. This could be when there's some type of infection from pathogens like cystitis or a bladder infection, or pyelonephritis, which is a kidney infection producing very high fevers as well. Very dangerous. So this was the last slide. You can stop the video here, go back and review this section. Let me know what questions you have. Hopefully I didn't go too fast. Actually, while I'm talking, I want to look over my notes and make sure I covered all of the important things, if you know what I mean. And I did, I think. Ascending interstitial fluid. I don't let you go until I have it all done. Yep, I got it. Our next chapter is even more amazing because it puts everything that we've learned together in a nice, happy bow. So have an awesome day. Bye. See ya.